गुड इवनिंग। गुड इवनिंग डियर फ्रेंड्स। आज हम एक बार फिर से मेडिकल न्यूज़ लेकर आए हैं और इस मेडिकल न्यूज़ में बहुत ही कॉमन चीज़ एबनॉर्मल यूट्राइन ब्लीडिंग के बारे में बात करेंगे। और बात करने के लिए हमारे साथ हैं डॉक्टर अर्पणा हरित्वाल, जो कि बहुत ही लीडिंग गायनेकोलॉजिस्ट हैं। आप मैक्स साकेत में प्रैक्टिस कर रही हैं, साथ में शारदा क्लिनिक आ रही हैं और मोस्टली से पेशेंट्स की ये जो प्रॉब्लम है उसे आप बहुत अच्छे से हैंडल कर रही हैं। और इस बातचीत को जारी रखने के लिए हमारे बीच में है डॉक्टर बीवी गुप्ता, जो कि एक लीडिंग फैमिली फिजिशियन है साउथ दिल्ली के। आप आईएमए के भी हमारे बहुत सारे अहदों को सुशोभित कर चुके हैं। तो मैं डॉक्टर बीवी गुप्ता को इनवाइट करता हूं कि वो डॉक्टर अर्पणा हरित्वाल से जीपी वाले सवाल पूछना शुरू करें। डॉक्टर बीवी गुप्ता।
Thank you, Dr. Divakar. Good evening, Dr. Arpana. It is my privilege to talk to you, Dr. Arpana, today about a very common complaint in my female patients of unexpected or unexplained vaginal bleeding. It is a problem which perplexes, embarrasses them, and causes anxiety in young girls near menarche, and also causes anxiety in their parents and caretakers. Similar situation is faced in adult female patients nearing menopause and causes anxiety into them also. You might also be getting anxious female patients in the sexually active age group with such complaints and situations. Please enlighten us about the technical aspects of this problem, what it is technically called, and so forth.
Good evening, Dr. Divakar and Dr. Vivi Gupta, and thank you for giving me this platform to speak on such an important topic. Now, to know what is abnormal uterine bleeding, actually we should know what is a normal uterine bleeding. So females have a normal menstrual cycle. A normal menstrual cycle lasts for about 7 to 9 days. It has a frequency of 21 to 38 days with an average blood loss of about 5 to 80 ml. So anything out of this, if a female is having her menstrual cycles less than every 21 days or more than 38 days, if a female is having her periods lasting for more than 9 days or just for less than 1 day, or if her menstrual blood loss is less than 5 ml or more than 80 ml, that constitutes abnormal uterine bleeding. Clinically, I would say amount of blood loss, if in patient's language, we can say that if she is using just 1 pad per day or it is more than 6 fully soaked pads per day, then that is included in abnormal uterine bleeding. Also, intermenstrual bleeding as well as postcoital bleeding, that is also included in abnormal uterine bleeding.
What are the causes and etiology of abnormal uterine bleeding?
So previously we used to just say that she is having either irregular bleeding or heavy bleeding or scanty bleeding. So in layman's language, yes, these terms are okay. But from medical point of view, the Federation of International Obs and Gynae in 2011 has given the classification according to the causes of abnormal uterine bleeding. So that is a PALM-COEIN classification, PALM, COEIN. Now, the PALM part includes the structural causes. P stands for polyp, A stands for adenomyosis, L stands for leiomyoma or fibroid, and M stands for malignancy or hyperplasia. So these are the structural causes of abnormal uterine bleeding. Now, COEI, that is the non-structural causes, the non-organic causes. So C stands for coagulopathies, O stands for ovulatory dysfunction, E stands for endometrial disorders, I stands for iatrogenic, either because of drugs or IUCD, and N is not otherwise classified. Now, in not otherwise classified, we include tuberculosis, endometritis, pelvic inflammatory disease. So these are included in not otherwise classified. So these are the main causes of this PALM-COEIN classification completes all the etiologies of AUB.
You said some drugs are also implicated in causing abnormal uterine bleeding. What would be those drugs?
So the drugs are blood thinners. If some patients are on blood thinners like heparin and ecosprin, then antipsychotics, antidepressants, and even NSAIDs. So these are the most common drugs which are included in causing abnormal uterine bleeding. And another thing is even these oral contraceptive pills, then emergency contraceptive pills. So even their use, their unindicated use can also cause abnormal uterine bleeding.
When you are taking history of such a patient, or I am talking to the patient initially, what point should be elicited in the history?
So history part is very important from the general practitioner point of view, even for specialist point of view, because just by taking a proper history, we are able to correlate the cause related to her problem. So in history taking, first of all, menstrual history is very important. What is the frequency of her bleeding? What is the duration of her bleeding? What is the amount of blood loss? So if the patient is giving history of heavy menstrual bleeding, so heavy menstrual bleeding can be related to fibroid uterus, adenomyosis uterus, malignancy, or hyperplasia. But if she is giving history of intermenstrual bleeding or postcoital bleeding, then in that case, polyp or IUCD can be the cause. Similarly, if she is having irregular uterine bleeding, so in cases of irregular uterine bleeding, usually patients give history that they have a history of a secondary amenorrhea of about 2 to 3 months, and then they have heavy bleeding after that amenorrhea. So that type of bleeding is usually related to ovulatory dysfunctions, such as in PCOS patients, or if they are having some endocrine dysfunction like thyroid problem or hyperprolactinemia. So these can be the causes implicated in cases of irregular bleeding. Another pattern of bleeding can be amenorrhea or scanty periods. Now, amenorrhea or scanty periods can be seen in patients who have cervical stenosis or who have Asherman syndrome.
But that would not be causing abnormal uterine bleeding, na?
No, sir, that is again abnormal, I told you, na? Because
okay.
Scanty bleeding is also abnormal. Not only heavy bleeding is abnormal, scanty bleeding is also abnormal.
Yeah.
Heavy bleeding always terrorizes us, so we don't look for a scanty
So we
bleeding.
don't consider that. But actually, that is also worrisome for patients. And yes, definitely there is some pathology which is causing that.
Okay, thank you. Dr. Arpana, how would you proceed with the examination of such a patient, and what investigations would you advise?
So from investigations point of view, first of all, getting a urine pregnancy test is a must. So we must rule out that if the patient is pregnant or not, because here what we are talking about, abnormal uterine bleeding, is outside of normal pregnancy. But in pregnancy, supposedly if patient is having ectopic pregnancy, in that case she can have abnormal bleeding. Supposedly if patient is having inevitable abortion or threatened abortion, she can have abnormal bleeding. So we have to rule out pregnancy first of all. So a urine pregnancy test is a must in any case of abnormal uterine bleeding in a reproductive age group female. Then after that, we have to get a CBC done, because sometimes patient might be bleeding for long and she must be anemic. So first of all, a urine pregnancy test in a reproductive age group, then a CBC, then coagulopathy has to be ruled out by getting a PT, APTT and INR levels done. In coagulopathy, we must also take if she has history of heavy bleeding since menarche, if she has history of easy bruisability, or if she has any family history of bleeding disorder. So this is the important point in history to rule out coagulopathy. So for coagulopathy, we have to get PT, APTT and INR levels done. Then to rule out any endocrine dysfunction, we have to get the thyroid and prolactin levels done. So these are the blood tests which are mainly done. Then after that, a transvaginal ultrasound is the main modality of choice, investigation of choice in AUB patients. MRI is usually not needed. It is done only once we get a transvaginal ultrasound done, and then if required, we have to go for MRI. Otherwise, transvaginal ultrasound is the basic investigation. Then after that, hysteroscopy or sonohysterography can also be done.
What would be the medical or surgical modes of treatment? Proceeding to the treatment.
In cases of AUB, medical treatment is always the first option. But again, whether we have to go for medical treatment or the surgical treatment, that depends on certain factors, like what is the patient's age, what is the clinical stability of the patient. If she is having acute bleeding, then definitely she has to be acute heavy bleeding, then she has to be hospitalized, stabilized, and then investigated, and then find out if she requires surgery at that moment or not. But there are various factors which determine whether we should go for medical or surgical treatment, like patient's desire for future pregnancy, if her family is complete or not, and if she's having some gross abnormality, like if it is malignancy or a big fibroid uterus, and it is causing a lot of symptoms to her. She's having pressure symptoms, which is disturbing her quality of life. In that case, we have to go for surgery. But definitely medical treatment is the first option.
I keep on hearing so much about Mirena. What is that? Is it a medical treatment or an interventional treatment or what?
So Mirena is a medical conservative treatment basically. So we are not. It is just like a intrauterine device, and it contains the hormone levonorgestrel 20. So this Mirena is like a copper T. Okay, so it is inserted inside the uterus, and it causes endometrial atrophy by increasing the local progesterone concentration in the uterus. So it is a very effective treatment for abnormal uterine bleeding, and it has saved many hysterectomies. So patients must go for this Mirena insertion. And the myths associated with it are that sometimes it can invade, it can perforate inside the uterus, or it can cause heavy bleeding. So they are just the myths associated with it, and it is very much tolerable, doesn't cause much. It just has minimal side effects like some amount of pain and some amount of irregular bleeding, spotting kind of bleeding for about 5 to 6 months.
And how long the Mirena can be left inside?
Mirena has a time period of 5 years, but its efficacy for prevention for this hormonal imbalance, for maintaining the hormonal balance, is for up to 3 years. So after 3 years, it has to be changed. It can work as a contraceptive up to 5 years, but its efficacy for prevention of abnormal bleeding lasts up to 3 years. After that, its efficacy starts decreasing.
And if it causes atrophy, means it will be advised to only female patients who have completed their family?
Yes. Yes, I would like to tell you something about the medical management. So in
Yeah.
the medical management options, actually everybody knows that if anybody is having abnormal uterine bleeding, they have to go for surgery and the uterus is to be removed. So it's not like that. As I told you, that medical management is the first option. And the medical management includes oral contraceptive pills, which have to be given for 21 days every month, and up to 6 months they can be given. Then we can give a break for about 3 to 4 months, and then we can again repeat it. So oral contraceptive pills are the first choice for medical management. Then oral progesterones can be given, medroxyprogesterone acetate and norethistron acetate. They come by the brand name of Remolut and Meprate and Regestrone. So their doses 10 to 30 milligram per day in divided doses. So oral progesterones can be given. Then this Mirena insertion can be done. Then injection DMPA 150 milligram IM every 3 months. This can also be given. So these, and then tranexamic acid. So it has antifibrinolytic activity. So tranexamic acid can be given. So 500 milligram 3 times a day for 5 days in cases of heavy menstrual bleeding. So these are the medical management options available, and we should always go for medical management before straight away going for a surgical option.
मैम बहुत छोटा सा क्वेश्चन है कि नॉर्मली क्या होता है कि कहीं पर भी बॉडी
कितनी
में
ब्लीडिंग होगी कि जिसको हम हैवी कहेंगे,
या जिसके लिए मैम हमें
पैनिक
उसको
पेशेंट होगा तो
उसको हॉस्पिटल भेजना एडवाइस करेंगे. पेशेंट पैनिक में है, वो कह रहा है मुझे इतनी ज़्यादा ब्लीडिंग कभी नहीं हुई, अभी ब्लीडिंग हुई है. अब ये हमारे को डिसाइड करना है.
पेशेंट नोज द बेस्ट, पेशेंट नोज द बेस्ट. अगर वो कह रही है कि हैवी ब्लीडिंग है,
नहीं
तो शी नीड्स टू गो.
मैम हम उसके डिसीजन को कहीं डाउट नहीं कर रहे, हम मान रहे हैं कि उसको हैवी ब्लीडिंग है, लेकिन उसका सवाल है कि क्या मैं हॉस्पिटल में एडमिट हूँ या नहीं, या मुझे ब्लड ट्रांसफ्यूजन की ज़रूरत पड़ेगी या नहीं. इस सवाल का हम क्या जवाब दें?
So if you do the examination of the patient clinically, if she is looking too pale,
okay,
then you can decide that yes, she needs to go. And if she is looking very pale, if she is having hypotension, if she is having tachycardia, then in that case it shows that yes, she is going to be in shock condition. So then she needs to be transfused IV fluid followed by blood, and she needs to be admitted.
Thanks for
that.
that.
I mean, if she's in hypovolemic shock.
Yes.
That is the main problem, because road accidents में भी थाई में जब चोट लग जाती है तो they lose a lot of blood, and in due course of time we see a hypovolemic shock in road accidents or some sort of an injury which is not so severe, trivial, and there is no external blood loss. So it is very difficult to find out कि that is the where we are going to lose a patient or not. So that was the same question I put up to you. Thanks, it was a beautiful answer, and definitely we should look for the signs and symptoms of a blood loss or a fluid loss into the body. Sir, over to you.
It was a brilliant presentation, Dr. Arpana. Even for a GP like me, quite many things have become clear. So that's all from me. Thank you.
So it was a beautiful talk, and the way you took the whole journey to the final destination, I really want to thank you, and thank you so much, ma'am, for putting everything into such a black and white. Thank you so much. Thanks a lot.
Thank you. It was a colorful presentation. Thank you.